Morning, morning, everybody. Everything is looking good. Looks like the mic be a bit too high. That looks better. Hope everyone is good. Monday morning, and what a busy week last week was. Thanks for those that came to Therapy Expo in Birmingham in the NEC. Good to see some old faces and meet some new people as well. And it always surprises me how many people that I know are there. And we've got some great feedback as well from some of our anatomy courses, which was really good. So thank you for that. Right, let's get going. Where are my comments gone? There they are. So if you want to make a comment, just pop a comment in the comments box. Morning, Tris. Just like Tristan's done there. Good morning, mate. Good to see you. And let's get going. So we were looking at the hip rotators last week. So all of the kind of rotator cuff for the hip, we called it as. Yes, good to see you as well, David. Hope you had a good day. Definitely camera. I think people are surprised at how tall I am. Obviously really, really tall when you see me in person. Let's move on to the different sections of the hip and thigh. So we started to look at the gluteal muscles last week, so we'll crack on with that again today. So I've grouped these areas into regions. So we're looking at posterior thigh. We looked at kind of deep gluteal region last time, and we talked a lot about deep gluteal syndrome and the fact that it used to be called piriformis syndrome, and hopefully you can see from last week why the name was changed, because we couldn't be that specific. It doesn't really change what we do in terms of treatment, but it's just not blaming one thing for the issues. You're absolutely right. Yeah. Definitely. It was mad because we've got Dan Williams, who I used to work with in Birmingham, who's like 7 foot tall, and then there was Gary Benson there, who's head of the STA. He's about 7 foot as well, and who else was there that was really tall? But I had a picture taken next to them and it just looked like a dwarf. Got to choose some smaller people to have some photos with next time. Glute max. Yeah, we had a look at this a little bit, and I was particularly pointing out these areas around here and these areas around here, because I think hopefully if you remember, we were talking a bit about how bursitis gets misdiagnosed, and quite often it's more likely to be a tendinopathy than a bursitis. So on imaging, the bursa is fine, and problem with a tendinopathy is it doesn't show up on imaging. Yeah, if it's in the latter stages, so if it's inflamed, then you will see something on ultrasound, but otherwise not really. And it's more to do with the story. So listening to somebody's reasons why they have the symptoms. And like I said, we're going to do an episode where we include a bit about tendinopathy in there in a bit more detail. So I'll talk about that in a bit more detail then. But something to bear in mind is the classics with tendinopathy is it's fine when you're moving. Yeah. So people who are active, or even if they're not very, very active, they're fine once it's got warmed up. Yeah, so they're moving around and it's okay. It's when they stop and then they go to get up again, and then they're like, "Oh, that's a bit sore." So that's a classic kind of tendinopathy presentation. And if it was a bursa, it would be inflamed and irritated throughout the movement time. Yeah, so it will get irritated by the friction, usually with activity. So the fact that it's better with activity is pointing more towards a tendinopathy. So yeah, it's that's one thing that you can look at. But some of the key areas, obviously, we mentioned around the greater trochanter, because that's where a lot of the bursa are. There are quite a few around this area that we looked at last week. But this area here is a real hotspot usually for gluteal tendinopathy. And well, the other thing is the training errors as well. So if dig a little bit deeper into their history and seeing if they've just started taking up some kind of activity that they don't usually do, and that can be a contributing factor as well. So yeah, obviously we take everything rather than just the anatomy itself. You've got to take the whole story as well. So in terms of anatomy for this glute max, obviously most of it attaches into the IT band, but we do have a portion, so the distal portion, that attaches into the gluteal tuberosity, and that is the bit on the back of the femur. If you get someone side lying, have a feel down off of the greater trochanter and then just behind the greater trochanter onto the bone, that's usually the hot spot. Yeah, and it's usually really quite tender there, but up here can be tender, too. Okay, so for glute maximus, and then glute medius, we looked at this again last week. It's a little bit further around the front, so attaching onto the greater trochanter, and again, usually it's this kind of area here, just kind of under the iliac crest, and people will often complain of back pain. And obviously we need to investigate that fully, but if you're poking and prodding around here and that's reproducing their symptoms, then that's not their back, which is good, it's their pelvis. So it's more likely to be those muscles, and again with the rest of the story as well. And then the last one is this one, glute minimus. So we've got these 3 layers of tissue, and they're all attaching in slightly different places. And if you haven't seen the bony anatomy part of this series yet, then we talked about some gluteal lines, and there are these lines on the outside of the pelvis where the gluteal muscles attach. So this is another one of those gluteal lines. So if you have a look here, at the origin on the ilium between the anterior and inferior gluteal line. Yeah, so, and again, people will often kind of push into the side of their gluteal muscles and say that's where it's sore, and they'll go, it's my hip that's sore. But the good thing is, here is not where your hip joint is, that is down here. Yeah, so again, having an accurate idea of where the anatomy is helps you try to then focus your questioning or your clinical testing, because that they may say hip and you do all the hip test and they're fine, but if you do some poking and prodding and muscle testing around this area and dig into the history of them using these muscles, maybe that will give you a bit of a better story. But the attachment for this one is onto the greater trochanter as well. Yes, we've got glute medius and minimus attaching into here, and then this one just sits under that medius muscle, which is laying over the top. Okay, so we've got these 3 layers of muscles, 3 big muscles, and this is what they look like. So this is glute maximus. Morning, Penny. Just seen you creep in there. And Steph, morning. So here we are. Let me just pause that. There, is it paused? Yep, there we go. Okay, so just give you a bit of an orientation. So this is your glute maximus muscle, and again, these videos are from Ackland Anatomy. So if you want to get the whole set, then those are available online now. Used to be DVDs, in fact VHS. Back in the day. So yeah, we've got this is your iliac crest, the posterior aspect. This is the anterior aspect leading to the ASIS at the front. Greater trochanter is under there. Okay, so this is the kind of beginning section of your IT band. There's your gluteal muscles there, so you can see the fiber direction, and if we have a look at what the actions of this muscle, we've got extension, lateral rotation, so rotating the femur laterally out towards the outside, and then abduction, so taking the leg away. And so different parts of the muscle will do different things, but obviously it all then works together. So we've got that sideways movement, rotating outwards and extending the hip backwards. That's those are its roles. Just play that through again. So there's the attachment point at the back, and it's also onto the sacrotuberous ligament a little bit here as well. There's your ischial tuberosity. So that massive muscle here. Greater trochanter is just under there. There you go. And you can see the hamstrings just here, just creeping under the glutes as well. And then there's the gluteal tuberosity. So that's the bit that I was saying. Just going to pause that. For some reason it's not showing that. Let's try and get rid of that. Nope. There we go. Oh, it's just lost it again. Yeah, it's not allowing me to control the video for some reason, so we'll watch it through again. But yeah, the where that ischial, the gluteal tuberosity is just underneath this greater trochanter, so down here. So that's the bit to have a feel of for gluteal tendinopathies as well, because we often just think it's greater trochanter, but it can see that roughening of the bone just there. That's that point where the glutes attach. So we'll do it there. Greater trochanter just under there. So you find your greater trochanter, side lying is best, and then you just drift off down here onto the back of the femur, and then that's the gluteal tuberosity just there. Okay, so have a look out for that one. And then this is glute medius. Here we go. So they've taken glute maximus off, and there it is there. Morning, no worries. So there's your glute medius there, attaching onto the greater trochanter, and you can see its relationship with the iliac crest. So again, this is a real hot spot for tendinopathies, because that's a tendon too, albeit a broad one, and obviously down here. But people feel this real kind of achiness all along here, and that is also a classic somatic referral. So a referral of from the body. When you're pushing on those muscles, they can often refer down the thigh, usually the back of the thigh, kind of down to the back of the knee, and maybe into the kind of outside of the calf a little bit as well. So it gets people a bit worried that they've got a problem with their disc, L4, L5 disc, because obviously that's the kind of referral pattern for that region as well, that radicular symptoms, or those radicular symptoms. But glute medius and glute minimus can refer into that kind of area as well. So it's definitely something to check out. You can have a good old poke and a prod around there, and if it's reproducing their symptoms and they're getting the pain down the leg, then you can include it into the mix of things that you might want to consider is their issue. So let's have a look at that one again. Okay, so it's the same side as the previous one. Here we go. Yeah, video layer. There's something wrong with the video layers today. Don't know what. There's your greater trochanter just there. So you can see all your hip rotators that we looked at last week. And then there's your glute medius. Yeah, so filling that area there. So have a good old poke and prod underneath that iliac crest, as well as on this greater trochanter, because these are usual kind of hot spots. And if you do shockwave therapy, in particular, this kind of thing that I do, then that it's all around that area that's usually symptomatic, and again reproducing people's symptoms. So that's those are good places to look for as well. And then the last one of the glutes is this one. So this is your glute minimus. So this is going to be the smallest one, hence the name. And here we go. So this is it with nothing on, and then there's your minimus. So you can see it's sitting underneath that medius that overlays it. and it's again attaching onto the greater trochanter. And again, this kind of region here, that rainbow of muscles all around that area there, that's usually where people go, that's where it's sore. It's kind of like right in there, that's where they can feel it. But their hip is here. Okay, so if you can reproduce their symptoms in here, and you do your hip tests and your hip tests are all clear, then again you can put that into the mix. So deep pain on the outside of the greater trochanter, would this be glute max 2? Possibly, yeah. It's usually because it's overlaying the greater trochanter. It would be over there usually, or on the gluteal tuberosity. Yeah, those are your key spots to have. But basically, have a really good poke and a prod, because palpation has had a really bad name. Yeah, so everyone's going, oh, you can't feel this, you can't feel that. You know, it's unreliable. And for a kind of specific diagnosis, yeah. But if you aren't dealing with an injury, you're dealing with pain, and you can't see the pain on a scan because there's no injury there. So when it's an overworked muscle, a fatigue soreness, so that is palpably tender. So when you push on it, it reproduces their symptoms, and then they get the referred pain as well. Okay, so I think we've kind of like shied away from it a little bit because of the negative press that it's got, but actually it is quite useful, but not on its own. Obviously, it needs to be part of your clinical reasoning. But yeah, I'd definitely be having a poke and a prod around here, all around there, gluteal tuberosity, greater trochanter, all around that area. Yeah. The amount of times I've had people come in and say, oh, I've been told, and this is no slight on GPs, but it's mainly GPs that I've had the experience with, and they've said, oh, it's lateral hip pain, bursitis, and you push and you prod on the greater trochanter, even with imaging, there's nothing there. But then you go a little bit higher into the gluteal muscles, and that's where the symptoms are. So it's, yeah. We take from that what we can. So the other muscles that kind of influence this region, this kind of posterior aspect, although this one's a little bit more anterior lateral really, is tensor fasciae lata. So it's tensor of the white fascia. So obviously we're tensing up your fascia is your connective tissue, and in this case the iliotibial band. And then obviously your latte is white. And I've been listening on the radio, travelling to the NEC this week. Apparently the Italians have no idea what a latte is, and we're desecrating coffee by adding too much milk. So you'll get a glass of milk apparently if you ask for a latte. So yeah, there you go. Coffee education as well as anatomy. So tensing the white fascia is what this muscle does. That's where it attaches. So right on the front of the iliac crest. And it's, again, that same kind of region as the gluteus medius. Yeah, so around this kind of area, but right at the front. So ASIS is right there. So again, this is another one, or another area to have a poke and a prod. So do you know whether it's glute med or do you know whether it's TFL? It's going to be one of them. Okay. Does it change what you do? Not really, because the actions of this muscle are very, very similar to glute med. And you may have heard the rhyme, tensor fasciae lata, gluteus med and min, all abduct the hip and rotate it in. Okay. There's a nursery rhyme for you. So tensor fasciae lata, gluteus med and min, all abduct the hip and rotate it in. So they do the same jobs. So if you're doing some rehab or some manual therapy or whatever for this region, of course you're going to affect the TFL as well. Yeah. So this attaches purely into the IT band. Yeah. So you've got, it's like the deltoid for the hip. So you've got the glute max coming around, and then you've got the TFL at the front, and they then both join together into the IT band that then well, the thickening part of the IT band runs down the side of the leg, but as we've seen, it wraps around the whole thigh. Yeah, so but it's that region that it's concentrated on. So the glute max will attach basically all around that edge just there. Okay, so they're both joined together. Let's have a look at the IT band. Just get rid of that one and play this one. Okay, so there's your fascia lata, there's your white coffee, just pause that there. And as you can see, this is what I was saying before, the fascia lata, the IT band, is not a band. Yeah, it wraps around your whole leg, and the only reason we see it as a band is because it's been dissected that way. All right, so when we do dissections of the leg, which there are still spaces available if you want to join me in London on the 18th of December. So, well, and this is the kind of thing we do. Okay, so we look underneath the layers. These aren't prepared already. Yeah, that these are specimens that we prepare ourselves. So I'll show you how to do it. But this is the kind of thing we see. So you have a look at the IT band. You remove the skin, and this is what it looks like underneath. That fascia wraps around the whole thigh. Yeah, there is a thickening here. You can just about make it out there. So what we do as anatomists is we cut along that thickened line on the edge of it to create the IT band, and then that's the image you see in the books. All right. So yes, Steph's coming. Yeah, good. Yeah, looking forward to that. It's going to be good. So yeah, that's what you'll see. Yeah, and but in reality, this is what it looks like. So your TFL will attach onto the front of this, the thickened area, and the glutes around the back. So let's have a look at that. So there it is, wrapping all the way around, and it doesn't just stop in the thigh, it comes all the way down as well. So the IT band is the thickening. There's your TFL, your transport for London. It's on the front part of the iliac crest, and then comes around to here, which is Gerdy's tubercle. And then there it is cut out. Yeah, so that's what we normally see, but that's not what it looks like. And you can see the quads underneath, hamstrings on the back, and it attaches via this septum here. Yeah, and we looked at the septums when we looked at the connective tissue. Yeah, so that's it coming down. There's your biceps femoris tendon, but that's where your IT band attaches right onto there. So that band has got your glutes coming in here, and then your TFL coming in there. So it forms like this, like I say, like a deltoid around your hip, like the deltoid in the shoulder, I mean. And then there's your transport for London. There's your tensor fascia lata just there. And then that's where it attaches there. So again, another area to have a bit of a poke and a prod in, but also down into the muscle as well on the front of the hip, because that's usually quite a sore area. And I can't, for some reason, I just can't rewind these videos. We have to watch them all the way through and then start them again. So get ready. We'll start this one again. Here we go. Okay, worth looking at this one again, I think, because it's it kind of blows a few myths. Okay, so there it is, fascia lata all the way around. Good to watch this one again, I think. So you can see it's covering all the hamstrings and everything, yeah, all the quads, patella, even down into the leg. So the IT band is the thickening. There's your tensor fascia lata just there. There's your ASIS at the top. So sometimes called the iliotibial tract. There's Gerdy's tubercle down there. So that's it just there. There's your biceps femoris muscle there. Okay. There's your ITB. There are your quads. Hamstrings under there. And then this is where it attaches onto the femur. And that's where it separates and divides the leg into compartments. And we looked at that a few weeks ago. Biceps femoris tendon will attach here, and then IT band onto there. and there it is there. Okay, so glute max coming in, TFL coming in around the front, and that's it all there. Okay, there's the TFL. Yes, have a good old poke and prod into that TFL. So one of the key things that this TFL does as well is flexion of the hip. It's not a massively influential hip flexor, but if you wanted to engage that muscle, then you just get them to lift up it. You put your hand on their knee, get them to lift up into your hand whilst you're palpating that area, and you'll feel the TFL just pop up. Yeah. So that again, you can have a bit of a poke around there and see if that's sore as well. So that's another one to check. Penny, just in your message, that is on you, I'm afraid. Yeah, so that will be your YouTube login that you'll need to update. Yeah, not me, that one, I'm afraid. Right, let's have a look at the medial thigh. So we're going to have a look at inner thigh as well. What time is it? Yeah, we've got plenty of time. So we've had a look at the hip rotators, so the deep gluteal muscles. Then we've zoomed out a little bit into the posterior thigh. Now we're going to switch into the medial part of the thigh, have a look at those inner thigh muscles. So the way to remember them, there's a few different ways, and my son was particularly proud of one of my Instagram videos the other day. That was an excerpt from one of the videos. So this is a way of remembering the adductors. 3 ducks pecking grass. So 3 ducks are your adductor muscles. So we've got adductor magnus, adductor brevis, adductor longus. Okay, so those are your 3 ducks. Pecking is pectineus. Grass or grass is gracilis. Okay, so 3 ducks pecking grass. Those are your medial thigh muscles, which are your adductor muscles. The way to remember the order of them in which they go, and this is the bit my son particularly found amusing, was please baby love my groin. Okay, so please was pectineus, baby was brevis, so adductor brevis, love is longus, adductor longus, my is magnus, adductor magnus, and then groin was gracilis. Okay, so that's the order in which they are as they from top to bottom when they attach on the medial aspect of your hip. So they're all pretty much all of them are supplied by the obturator nerve, and the obturator means to close. So that's why the obturator nerve, if it innervates those muscles, they're the muscles that close the legs. Okay, so that's those are there is an exception to this, but mainly the obturator nerve supplies the adductor group. Okay, so that, the group as a whole. So that's them. Apart from sod's law, this one came out first. Apart from this one, so the obturator nerve supplies parts of your adductor magnus muscle, but you also get a contribution from the sciatic nerve, which comes for the different fibers. So the adductor magnus has got different angled fibers. We've got vertical fibers and then oblique fibers coming across, and the vertical fibers are supplied by the sciatic nerve. And we've looked at this a little bit already when we looked at the knee. So the vertical fibers that are coming down here, that's sciatic nerve innervation. So whoever classify it as a 5th hamstring. You go, hold on, how come it's the 5th one? We've only got 3. But you've got semimembranosus, semitendinosus, and 2 heads on your biceps femoris, plus the vertical fibers of adductor magnus. So there's your 5th hamstring. Okay, so that's the exception. Yeah, so we've got innervation from a different nerve for this part of the adductor magnus. Now we have talked about this a bit in the knee, but it's worth revisiting it as we go up into the hip. Is this area here? So the adductor magnus has this hiatus, so it's got this gap, and that's really important because vessels from here, this is the same vessel all the way down the leg, just changes names as it goes. So a vessel will come over here and it will travel down here using the adductor magnus as like a bed to travel on, and then it will go through that hole. It won't carry on the front of the leg, and it will go to the back of the knee. Okay, and if you remember from when we did that, it changes into the popliteal artery when it goes behind the knee. Okay, so that little gap there is really important to get your blood supply from the front section of your thigh into the back and then down the back of the leg. All right, so this is really useful because that is your main artery to supply your whole leg, and it's useful in terms of first aid especially. So if you have some kind of catastrophic injury to your leg and it's injured the artery, then you can occlude the artery up here where it's really superficial. So in that femoral triangle that we've looked at, I think we looked at that last week, maybe the week before. And because it's quite superficial there, you can put pressure on it and it will stop the blood flow to the leg. So you can save someone's leg, or save their life really, from losing a lot of blood if you can occlude the artery up here. So again, that's where anatomy becomes quite useful. Right, let's have a look at magnus. Just get rid of those. So magnus first, hopefully this one. That's weird. I've got control of the video back on this one. Strange. Oh, I'll take it. So there's the picture from. So this is a picture from the Trail Guide to Anatomy book. It's by Andrew Beal, B-I-E-L. Really, really good book if you're just starting to learn anatomy. Some great clear pictures, but also nice to see them next to the real anatomy as well. So because these are really obviously nice and clean, but the real anatomy is a little bit less like that. And you can see the difference. The good thing is with the Trail Guide, you can see the different fibres. So you've got your oblique fibres and the vertical fibres shown on here. This point here is usually, again, another real hotspot for knee problems. And we talked about it when we did the knee. But the adductor tubercle is where your adductor magnus attaches down here. So it's a bit, let's see, it's tendinous. So that it's tendon from this point here, so that kind of last third of the muscle, and then down into a point right there. And again, you've got some other tissues overlaying it, so you can't be that specific. But that is usually a real sore spot for people if they've got a sore knee. Okay, and they'll often be again worried about their knee, but it may be the attachment of the adductor magnus. So it's again worth having a poke and a prod around there too. But this bit is the bit that is important in the transition of the blood flow. So when we add on the blood vessels, we'll revisit that again. But that's your adductor magnus. We've got these oblique fibres and vertical fibres just there. There's the hiatus. And then the vessels will literally come through the back and create the popliteal artery. But it's a massive muscle. That's obviously why it's called magnus. It's huge, and it's attaching up there just on the undersurface of the pubic rami. So if you have a look there, inferior pubic ramus. So there's your pubis, and then that's it. Oh, just there. Let me just pause that in the right place as it spins around. There we go. Okay, so there's your pubic bone, and that's the inferior ramus. So remember, ramus means a branch, so that's your inferior branch of your pubic bone, and then that then turns into your ischial tuberosity a little bit further back. So it's the ramus of the ischium and the ischial tuberosity as well for this muscle. It's huge, really big attachment points for that one. So that's your magnus. Let's have a look at brevis. So brevis is a little bit, I think we've got 2 in 1 on this one. Hold on. Yeah, so longus and brevis are in a video together, so I'll show you those both. So brevis means short. Okay, think of brevity, the word brevity. So we've got a short adductor muscle, and remember as well that we had, please baby, love my groin, or 3 ducks pecking grass. So this is one of the ducks, or this is the baby. Okay, so there's another muscle above this, if you did it in order, which would be pectineus. So if we have a look at where this one attaches, it's right on the pubic bone. Yeah, so just in there. This one and pectineus are classic areas where hernias, especially in guys, usually get misdiagnosed, or they get worried about it being a hernia because of the soreness around this area here. That's usually where you would feel it with a hernia as well. But if it's the muscles, then it's more likely to be a sportsman's hernia, which is a muscle irritation, basically. If you ever deal with professional athletes, and especially people who change direction a lot, then this area here gets really, really roughened. Okay, so remember that the bony landmarks are formed by pulling, yeah, on the muscles pulling on the bone, and that's why you get this increased lumpiness on the bones. That is really prevalent in sports people who play a lot of sport, and in my experience with footballers. Okay, so you'll get a lot of changes on these pubic rami around this area, and that's entirely normal. Okay, for sports people. But you can also get something called osteitis pubis, which is where the pubic bone itself becomes irritated. So there's a few different things that can go on around this area that could be hernia related or stress related, either to the tendon or the bone. Okay, so it's a real hot spot for those kind of things. So we've got a pectineal line on the femur, that's where it attaches down here, and the body and the inferior ramus of the pubis, so that area there on the pubic bone. So that's your brevis, so the short one. The longer one, is a very, very similar attachment. I mean, look at that, how close that is. So anterior surface of the pubic body, so it's coming a bit more around the front, this one. Again, it's a bit longer, it's a bit wider as well, this one. It's the middle third of the linea aspera, which is the white line on the back of the femur. Yeah, so it's attaching into there. So where brevis was a little bit higher, this one sits a little bit lower and in a little bit higher position on the pubic bone here. So again, we've got another muscle that can be contributing to symptoms right near the pubic bone. Okay, so right on that spot there. So that's adductor brevis, adductor longus. Let's have a look at those. Just pop that one back on. There we go. So just pop that there. Yeah, so we've got longus obviously means long, brevis means short. There's your adductor magnus. All right, so you can see the relationship between all of these muscles. There's your brevis just coming in there. So there's your pubic bone, greater trochanter, and obviously this is labelled up already, but your femur just there. So just to give you a bit of an orientation. So there's your longus, and there's the magnus behind. Ooh, let me just pause that at the right point. Ooh. There we go. Okay, so there's your brevis, there's your longus, and there's the magnus tucked behind. Okay, so you can see the relationship between all of these muscles. They kind of overlap as from each other as well, or on each other. So there's brevis just a little bit higher, then there's longus, and then there's the hiatus, so that has to be magnus just there. So that's brevis and longus together. There's the attachments. So again, this is obviously near intimate areas for people, so you have to be really clear with your direction if you do examine this kind of area. And again, you can image this area with ultrasound. You can have a look at the attachment points here. Obviously, if you find anything or you're not sure, then you can get an MRI done of this area. But the other considerations are the hernias. Okay, so and I did a whole session on hernias. I think it was a couple of years ago. So I think it was literally titled "All About Herniations." I think something like that. So yeah, if you want to have a look at videos on that, then just have a look at the back catalogue. But yeah, this area here, there's obviously a lot going on, so it can be a bit. The picture can be a bit confusing. I have seen someone who thought it was a sportsman's hernia, and I wasn't really happy with what they were saying, because usually with tendon problems, like I was saying before, they were okay when they're active and when they're warm, and sore when you kind of get up, and sore when when you've been rested for a bit. But with this particular person, it was like sore all the time, yeah, and sore at rest, sore when they ran. It just didn't really change. So we sent him for a scan, and he'd had a hernia and needed an operation. So again, it's not just the location. You obviously have to think about the location, but all the other structures that are there, and then going through the story to see what makes sense. Yeah. So yeah, this area, there's a lot going on. Okay. So if you're at all unsure, then I'd definitely refer. But yeah, we've got some nice pictures here from the trail guide. There's your brevis, okay, attaching there. Pectineus, which we haven't looked at yet, and then longus just there. So those are your attachments for those, brevis and longus. And then there's the magnus attachment on the round by the linea aspera. There's your brevis, and there's your longus on there. Okay, so they're all really close to each other. Cool. What time is it? Perfect. I think we'll leave that one there. So we'll do a bit of a recap on those next week. Just change my screen. Get rid of that. Pop that in. There we go. Yeah, we'll do a bit of a catch up on those next week. So we've done the posterior thigh. Obviously started the medial thigh, nearly through it. We'll pick up the rest next time. If you've got any questions, pop them in the Facebook group. And yeah, if you have heard about these sessions and want to be part of the group, then you can go to learnanatomy.online to have a look at that. Yeah, and like I said, we've also got the diary for next year for Scotland and London pro section labs as well. They're online at the moment. So if you're interested in coming to the labs with me and doing some anatomy for real, then feel free to have a look at clinicalanatomy.education. Okay, cool. I will see you next Monday, 10 o'clock.